Where'd you find this?
Go on, make it happen.
And now here's Steve and Michelle.
Welcome to Mallett and Michelle. Happy belated Valentine's Day. Where this week chocolate's on sale, the roses are dead, and it was Steve's birthday on Valentine's Day. Happy birthday, Cupid Steve. He aims at the heart, but hits mostly at your to-do list. And I'm Michelle.
Rapid fire.
That's right, the Queenager. Did you know I'm called a Queenager?
Queenager?
Yeah,
Oh,
TCOB. Taking care of business. Did you know that's what that means?
I did know that.
You did?
You didn't surprise me with anything.
Oh, really?
Yeah.
Oh, well, just wait, Steve. Buckle up, because this one's going to be fun.
Here we go.
This one's going to be fun.
Our guest today is going to be Gretchen Palmer. She's an OBGYN nurse practitioner at Ascension, Seton in Austin. 16 years she's been in practice, specializing in obstetrics and gynecology.
That was a mouthful. I'm glad it was your turn to introduce.
Yeah, but I'm excited to have her in here, so she'll be in here in a second. We'll get to talk to her about all things women's health. But first, could not do the show without sponsors.
Our sponsors, of course, we are Mallett and Michelle, but without Mallett and Michelle, we wouldn't know. Without these sponsors, we wouldn't be Mallett and Michelle.
There would be no Mallett and Michelle.
There would be no Mallett and Michelle. Deep Eddy Vodka Tasting Room.
Fun and flavor are on the menu at the Deep Eddy Vodka Tasting Room. Get your fill today.
Jovi Belterra.
Apartment living for sophisticated people 55 and up looking to live their ideal life with all their new best friends.
How about South Star Bank?
Sometimes you just want to walk into your local branch and get superior service and reliable answers to your questions. Those are two great reasons to bank at South Star Bank.
And these people have been really, really busy lately. We had to walk around the building a couple of times
like
today.
3 or 4 times, yeah. You forgot the name, though.
Oh, wait. Oh, yeah. Oh, what's her name? Mallett
Mallett Integrity Team. What happened to competent real estate agents? No social media influencers in the wild at the Mallett Integrity Team. Just top-notch agents doing great work for their clients.
Absolutely. And to unwind from all of that, you guys don't forget about Swampy Tonk. Steve and I are going to be emceeing that event. That's March 28th at Pigpen. You are going to have your headliner, Uncle Lucius, Adam Hood, Curtis Grimes, and then, of course, Logan Papp and the Cunningham
Jackson
sisters.
Bennett is going to be there with them,
That's right.
Yeah,
That's right. I think we slipped Logan some gas money.
Yeah, we
too.
did. Yeah, it's going to be fun. I think we'll have a good turnout for that. They've already sold out of the VIP tickets, so there's still general admission, and you can go to what's the website?
Oh no! What is the website?
Oh, here we go.
Oh wait, it's outhousetickets.com.
Outhousetickets.com. Swampy Tonk, music and mud bugs.
Outhousetickets.com.
Yeah. Well, in our studio today, Gretchen Palmer. Welcome to the show.
Hello, guys. Thank y'all for having me today.
Michelle and I have been prepping for this one, all about women's health, and she says you are the expert, so we're going to jump right in and figure this thing all out.
That's right. She is the expert. She is the local expert or the all-around expert.
Yeah.
She knows more about women's health than anybody I have personally ever met.
I know you're a fan. I can tell.
Imagine this. You're on a table. You're indisposed. You're sitting on a paper thing or whatever, a paper blanket, and you have a paper dress on, and you're like, I need you on the podcast. That's how that works.
Can't say no to that.
Can't say no to that. I mean, for sure.
Gretchen, how long have you been been a nurse practitioner and been with Ascension and all that? Just give us kind of a background of who you are.
Yeah, a little bit about myself. I've been in medicine for probably over 31 years now. Started off as a nurse, labor and delivery, so always in women's health.
Okay.
Decided to go back to school, and I'm a women's health specialized nurse practitioner. Been with Ascension for the last 8-9 years.
Okay.
Been in the Austin area for 16 years practicing.
Okay.
So,
Where'd you go to school?
of course, the only place in Austin to go, the University of Texas. And then did my master's level with the University of Cincinnati.
All right. Are you Texas born and raised?
I am.
Yeah, hallelujah.
I know, straight from Southeast Texas. That's why you might hear a little bit of a
Oh,
drawl.
where'd you grow up?
Close to Beaumont, Nederland.
Oh, okay.
Oh, no, are you kidding? That's where my best friend's from.
Oh, really?
Yes.
Yes.
Yes. Were you were, oh, wait, let me think about it. the Indians? Is that what the high school
no.
was? What was it?
We were Nearland Bulldogs.
Okay, I couldn't remember what it was. I think part of it, she went to a Catholic school, a private Catholic school, but her dad was a doctor there too.
Oh, very
So
nice.
yeah, nobody knows where that is. Nobody.
It's a that's why I always say Beaumont. It's much easier.
Much
Most
easier
people,
to remember.
most people will realize that one. Yeah, to remember.
And we were going to ask about, so you're a nurse practitioner.
Yes.
What's the difference between a nurse practitioner, doctor?
Well, nurses, they have a bachelor's of science in nursing.
Okay.
They practice at the bedside. They don't order. They don't diagnose. Physicians, of course, go to medical school. They have residency, fellowships, all the type of stuff. Different path, and nurse practitioners and also physician's assistants were considered advanced practice providers.
Okay.
So we have our masters or doctorates, and we practice in the state of Texas with a collaborating physician. We can diagnose, we can treat,
Prescriptions.
we can prescriptions, the whole bit.
Okay. That's pretty cool. I did not know all that.
I did not know that either. Yeah.
Well, so obviously a lot of our listeners are men, and we're going to talk about women's health. Can you give me all the reasons right now while the guys that are listening
All of them? All the reasons? All the reasons.
All the reasons.
All the reasons.
Some good reasons. Give me some good reasons why the men that are listening right now need to stay tuned in and listen to the rest of this show.
You know what? Actually, it could be that they're the most important audience that are even here today.
Yeah.
Being able to know what transitions that your partner is going through is so important, so that you know that they're not just going crazy or something's wrong in their minds or in their heads. There's some legitimate medicine behind it, and as our hormones fluctuate, just like a man can, even with their testosterone, the same thing happens to women. We just haven't heard a whole lot about it. So for relationships, empathy, it's a great, tools for your toolbox. It's a great thing to hear.
And we all want to be better husbands and partners, so yeah, that's the best reason to listen right there.
Well, and women's health is, in my opinion, so much more complicated than men's health, and so I want to kind of start.
That's a little sexist.
You know what? Suck it, Steve. Starting from the way.
I do agree with her.
All right, you win. Both
You're
of you
definitely
win.
outnumbered.
I'm just going to sit here and shut up.
Starting from way back, when girls start their menstrual cycles, when they are sexually active, when they become pregnant, when do you recommend that a young girl first starts seeing a gynecologist?
The standard of care right now is at 21 is when we do their first annual exams. We start pap smears at that time. That's actually shifted over the years. You might have remembered when you were younger that potentially our moms brought us in at 16 or 18. That technically doesn't happen until 21 now. Now, there's some other cases that they may need to be seen earlier, and that could be because they have irregular periods, they have painful periods, potentially they're sexually active and they need contraception or STI testing. So those are some reasons to bring them in earlier. However, usually it is at 21.
I did what any good sneaky teenager did, and I went to Planned Parenthood and did it all on my own back then, 17 years of age, and got on birth control. But I think the conversation is a lot more open nowadays than when I grew up in the 80s.
Oh, absolutely.
What do you think that shift, where that comes from?
Social media.
Good and bad?
Absolutely. We have TikTok, we have Instagram, we have everything that pushes that information out to the younger generation. Number one, I do think it empowers them. However, sometimes it can misdirect them, and we just need to make sure we have providers that can give good sound advice and be able to present that to them.
What are some of the things you've seen women coming in that they've seen on social media that are just out and out false? Have you seen some things like that recently?
Gosh, that's hormones would be definitely, how do we do this? I need, when we have a 23 or a 32-year-old woman that comes in with regular cycles and she wants a full entire hormone panel done, we know that that's not a standard of care. Sometimes we laugh that we're not necessarily like McDonald's, get it your way. We,
Okay, yeah.
there's specifics that we do, and we follow, the guidelines with healthcare and what things need to be done and what things are not relevant.
Yeah, I'm sure there's social media people out there saying you need to go tell your doctor this and tell your doctor that and tell them to run this blood panel and medicine by TikTok.
Yeah, Dr. Google, for
Exactly.
sure. Well, before we get into the meat and the really juicy stuff, how much, this is just strictly your opinion.
If you want to do your
disclaimer, but
disclaimer,
how much do you feel that insurance is guiding your, or just medical practice nowadays?
So right before we get going, let me just say a couple of things. We're going to cover a lot of stuff here today. I'm sure I see y'all's smiles on your faces and your list of your papers.
We got a long
all your
list.
questions that you have. But, as we go through this podcast, I just want to make sure everybody realizes that all the stuff we're going to talk about today is about educational purposes only. It is not medical advice. And, as we talk about menopause, women's health, there's so many things that can be different for each individual person. So I want to make sure that everybody seeks out that practitioner, that physician, whatever it might be, to get some sound advice and specific to their care.
Okay.
So that's number one. But how does insurance
Yeah,
play
how
into
is
this?
insurance playing into this?
I do believe that their access to care is very open. I think insurance allows that. Maybe your copay or, whatever it might be. Annual exams are typically covered by insurances. It's the medication side of things that becomes a little bit more difficult, where we need, insurance companies are not covering certain things, or the things that your practitioner or your provider may think is the best fit for you.
Without having to try 3 of them before that, because you know
Correct.
that those have already been tested. You're
Correct.
looking at your patient, that's not going to work.
Well, we have to go through prior authorization processes, and it just can be very cumbersome. There's a lot of things out there now that specifically that I use with even hormones that can be birth control and those type of things too. There's a lot of services. The HRT Club is one that I specifically use. And they're, in the United States, it was in Europe as well. But what they have come in, it's usually, just like all the Amazons and all the other type of online services you can get at cost. They're trying to bring those costs for hormones down.
Okay.
And really, you cash pay them. You don't even go through your insurance, but it's many times less than even what an insurance pay would be.
Yeah, it seems like a lot of the drugs that are going more direct, the prices have come down. I was just reading about some of the weight loss injections. They've gone from $1,000 a month to $150 a month self-pay. Yeah.
That's crazy.
Can you run us through, did you have a follow-up on that?
No.
Perimenopause, menopause, postmenopause, what are all those?
What does that look like?
Yeah.
Chaos.
Okay.
This is the thing that everybody's hearing about now. And I love it because sadly we have a generation, our moms out there, we consider them the lost generation.
Yeah.
And they did not get access to the hormones. There was a lot of fear, misinterpretation done on studies, and we'll go into that in a little bit. But really that focus on when does it start, when do I start treating, what does it even look like? So perimenopause, these are symptoms that can happen like 7 to 10 years even prior to menopause.
So this would be like early 40s, early to mid 40s?
It could even actually start in upper 30s.
Oh, really? Okay.
Yeah. Typically, you'll see anywhere between 40 to 58 is when a woman will go through actual menopause. Okay. And that is average about 51. And we consider menopause when a woman has not had a cycle in a year. So no period for a year.
Okay.
And at that time, we have no eggs left. We're not producing anything, no estrogen, no progesterone. But going back to the perimenopause, this is when we start feeling all those symptoms. And this is when we do think we might be losing our mind.
And you said that as early as in your 30s?
Yeah, sometimes we have women that can start feeling some symptoms late 30s. 40 definitely, 40, 42, 45. And some of the symptoms, there's like 80% of women, at least 80 or above, will say, top 5 things that they feel or they experience. Of course, the hot flashes and night sweats.
That's usually what pulls you in, right?
It is. You know that somebody's serious when they come in for those hormone consults because they sit there and like, I'm just burning up, and I have to change my, PJs in the middle of the night. My sheets are soaking
Drenched.
wet. Yeah. And, you have to think about that when you're doing that. What's the problem with hot flashes and night sweats? First of all, the person doesn't sleep very well. Cognitively, it can mess some things up too because you're not getting great sleep, and then we kind of get a little bit irritable maybe the next day, and that's not the best of things that we want to do. But hot flashes, night sweats. Another one of the top ones is weight gain. Always, always, always. Now, I always tell patients there's not a magic potion, not a magic pill, but with weight gain, what we see is we see that there's a shift. There's a shift from like subcutaneous fat in certain areas that we kind of move it to that belly fat area. And that's one of the things a lot of people will complain about.
One of the things, my favorite lines that people will say, women going through menopause who have especially gained weight, it's like, well, why don't you just eat less and work out? Calories
stupid.
in, calories out. Well, it's not that simple.
It's not.
Women aren't eating anymore. They're exercising probably a lot more because they're, their bone mass, and they're still gaining weight. And so it's a cycle. So you're saying
Correct.
that it's due to our hormones that is putting that weight on.
Well, there's a shift.
Okay.
There is a shift. I won't blame it all on that, but there is a shift where the fat actually goes more viscerally around our organs in our abdominal region. You always have patients that will come in and say, oh, it's this, tire that I'm carrying around my waist. What do I do about it? So there are things, and we can go into those now, we can do them later, but that we look at, and that's even from diet and exercise. Yes, because if you're not doing that, it's only going to make it worse. But that is, definitely something that people will report. Some of the other things that people report, anxiety, depression, mental fogginess, even panic attacks. Whenever you talk to women, 80% or more are experiencing those. Sleep disturbances. I mean, how many people come in and say, I used to sleep great, and now I can't sleep, and it affects my quality of life. Fatigue. Fatigue is another one that we find. But those are probably the top 5. And then, that's 80% or more people
And
will
that's
experience.
all perimenopause.
Correct.
Okay.
Correct. And that's such a great point because that is before you ever even get to menopause.
It's like, well, here's a little precursor to what's coming.
Buckle up, Buttercup. I'm gonna step back just for a second and tell the audience how I first came to know you, and so it gives a little insight, and I've talked about this before on the podcast, that I had a partial hysterectomy when I was 35 years of age. I had 3 C-sections, and I had a lot of adhesions, and so they went in to try to remove those adhesions, and I ended up having the hysterectomy. Flash forward to, I think I had it 3 or 4 years ago. I can't remember, 3 or 4 years ago. And some of those adhesions, it had adhered one of my ovaries to my intestines. So they went in, and I was like, look, I don't need them anymore. Take them out.
Take it out.
And I remember waking up in the hospital because I was reading all these horror stories, and you're going to wake up and you're instantly going to be in menopause. Absolutely instantly. And honestly, for the first 6 weeks, I was like, oh, this is a piece of cake. I don't know what people have been complaining about. And I thought, well, maybe because I had a partial when I was 35, that
Your
maybe
body adjusted.
Yeah, maybe my body just adjusted over the years. And it was one day I woke up, I think I was here in the office, and I literally felt like I was cooking from the inside out. And, my joints had really been aching and, all those other things, but nothing really kind of stood out until these hot flashes. So I went back to my gynecologist that performed my surgery, that does my annuals, and I said, look, I think I need to be on some hormones. And I see an endocrinologist too, and he's, love him. But he's like, oh, I don't do that. You go speak to your OBGYN.
Stay in your lane.
Yeah, stay in your lane. And I spoke to her, and she said, well, how old are you? And, I think I'm 52, 53 at the time. And she goes, okay, well, I'll try him out for you, but I will only do him until you're 60 years old, and that's it. And I looked at her, and I was like, I feel like crap now. Like, why wouldn't you want me to continue feeling good? So we started on this graduation of I was on patches first, and then she tried. Well, no, I'm sorry. First, she tried the estrogen vaginal gel, which I was like, no, I hated that stuff. And then it was the patches, and then I moved. No, I kept the patches. I just never was feeling better, and the patches would fly off or end up in my underwear, or my pants, or in the pool, floating around in the pool or whatever. And I went back to her, and she acted like I was almost inconveniencing her, that it was out of her scope of practice. And I said, I can't do this. I got to find somebody. And so I went into my girlfriends and I started asking, and Gretchen's name kept popping up over and over. And I heard about the HRT club. Don't worry, if your insurance doesn't pay for it, this will happen. And I remember going into her office and talking to her, and all of a sudden I felt heard and I felt seen for the first time. And you just don't know what that feels like when you're not necessarily calling you crazy to your face, but they're basically saying, oh, well, your labs are normal. I don't see it. Like, I have no ovaries. I have no kitchen. I have nothing in there. But I really felt like you first listened to me, and the way you explained it to me, literally, I was in a paper dress, and I was like, other people need to hear this.
Well,
so
thank you.
I'm not the only person, right? I'm not the only crazy person that has come in there. The only crazy person that asked you to be on a podcast. But,
that is true. Well, but you brought up some great points. Number one, not everybody and not all providers feel as comfortable with hormone replacement therapy, the transition, the perimenopause, as you had stated, the zone of chaos that we go through as we move into menopause. Lab work at that point really doesn't do us any good. And that is, one of the things that we try to educate patients on. Your estrogen level, I don't know what it was at 12. I don't know what it was at 24. And so I don't know what your estrogen level should have been at 52. So it could go all over the place. Also, I have to listen to the patients, because knowing what your symptoms and what you're actually presenting with is what I need to know to be able to accurately treat you. And that could be in the perimenopausal range. It could be in the menopausal range. And where are you? Yes, in some situations like a hysterectomy, we would do labs, because that is one of those case-by-case basis that labs would be effective. But if a patient's coming in, they're going back to perimenopause, periods are starting to get a little bit awkward, 7 plus or minus days up to 60 plus or minus days. We're skipping periods, we're doing those type of things. That's one of the things we really learn, and we see those other symptoms come along with it. So we have lots of tools in our toolbox to help you feel better. But the patients that have walked into my office, my front office lady, sometimes she goes, Gretchen, these people always come out crying. What do you do to them? I said, well, I don't hurt them.
It's got to be hope. They feel like nobody's listening, nobody's understanding, and they talk to you, and you give them hope. That's got to be. That would make me cry. I'd be like, I've been going through this hell for years. Everybody thinks I'm insane. Nobody believes me.
I'm a
and
bitch.
now all of a sudden, I'm talking to this person, and she understands. She gets it. And not only that, but she says, we can fix that.
Yeah.
We have some things we can do to make you feel better. I believe everybody should cry with that.
I agree. And I want you to now talk about the black box warning, that why all of a sudden this has just kind of been in the news and everybody's talking about it. And
I want to follow up on your situation.
What's up?
And I'm going to ask Michelle this, because I don't want to put you in a weird spot. Do you think your doctor said, I'm not going to continue it past 60 because of that black box warning?
I don't know the answer to that. Why? I thought there was some reason.
I don't want Gretchen to feel like she's.
So why in general would a doctor say after 60? What was is that?
So when we talk about the Women's Health Initiative, let's just talk about that first, okay? And that's unfortunately where that lost generation came in.
Which said that if you go on any kind of hormone replacement therapy, that you had a greater chance of breast cancer.
Breast cancer, cardiovascular disease, heart attack, strokes, all of that.
Okay.
And we found that honestly, when the black box warning, it didn't mean that hormone therapy suddenly became safe for everyone. what we did realize is that it wasn't dangerous for everyone. Okay.
Big distinction.
Yeah, big
That is, yeah.
Yeah. And so, but it was very specific to the individual person.
The reason why I correct me if I'm wrong, if I remember this story correctly, the reason why they were saying the 60 was because there was a study that when they started these women on, they finally started these women on hormones and they were in their early 60s, but they were already having some of these issues, right? The cancers and the, is that right?
Did you have a provider that might have told you that?
Maybe her name was Gretchen, I think. Is that right?
That is exactly right. So the Women's Health Initiative actually started, they got a group of women, about 161,000 women, ranging anywhere from the age of 50 to 79 in that period of time. The average age of women was about 65. And so it started in 1991. The total study came out in 2002. And what they were finding is these women started higher risk of breast cancer, having heart attacks and strokes. And all of a sudden they're like, oh my gosh, we have got to stop this study. The information that we're gaining, we have to take everybody off of hormones. And the theory really was smallest amount of medication for the shortest amount of time. We do know now that this study, because of some of the things that was used in this study, number one, synthetic hormones of estrogen. It was oral estrogen. They were synthetic. They were equine estrogen. Also, the type of progesterone that was used, it actually increased clotting factors as well. This particular one, it was not prometrium or micronized progesterone. And so all of this adding up did put women, especially over the age of 60. So what we learned from that is that, you know, we consider in our office there is a window, and many practitioners, providers out there do feel like there's a window. If it has been, you've been menopausal over 10 years without having any treatment, no hormones, you do become a little bit more at risk. Or if you are over the age of 60, as you were saying, that we choose not to start you on that because of the risk.
And that's the starting, that's not the continuing.
Correct.
Okay, that's where the distinction is. Okay.
Yes, if you were on it, I mean, as you are, when you get 60, I'm going to say absolutely, we're continuing it, unless you have some other risk factors that have shown up. If you've had breast cancer, those type of things. Many of the breast cancers are fed by estrogen or progesterone. It's not a cause and effect, but it is one of the things that can worsen it. So many of the oncologists in Austin will take you off of it.
But the other part of that study, which isn't talked about, is that, okay, maybe there's a slight increase in some other factors over here, but it gives you such a better quality of life. It just totally discounts all of that your life could be so much better for the remaining years.
Well, that's where you and I were talking when we were walking before the podcast. We were clearing our head a little bit, and we were talking about, I told Steve, I said, you know that a lot of these studies that are just out in general, they were done on men, that women's studies women have just been ignored forever, even in med school. So, like, you know, like I went to OBGYN. I went to somebody who I thought was going to have my best interest. It wasn't that she didn't have my best interest at heart. It was that she wasn't educated on it.
Yeah, and I do believe, you know, we have lots of providers out there, and I think people, you know, specialize and a little bit more some things than other people maybe. And, you know, one of the passions that I do have is for women of this age group and for women that are you know, having these symptoms. I was kind of that person that actually went through menopause at a very, very early age, in my early 40s, and had some symptoms. I had what was called an ablation, where I wasn't having cycles. So I really couldn't tell where my period was and where that was all over the place. And was there, you know, was there absence or was it more frequent? And at that point, I spoke with, you know, my provider, and not laugh, but they're saying, "Oh, Gretchen, that's in your head," you know. And so I finally, at that point, was able to get lab work and realized that that was it. And I think I take that. I think, you know, in many situations, you know, in my life, that God puts me through certain things, that I experience certain things that literally allows me to serve the women of the Austin area. because of that,
Yeah.
because of the experiences that you have, that you can go out and you have a passion, you have an empathy for that. And that's what I would say with many providers. Maybe that's just not their forte.
Right.
We do, I think more and more education's getting to where we find those things out. We learn more even with continuing education, but I think you got to have a passion for it.
Well, I think that I wouldn't go to my dentist if my arm was broken, right?
True.
And so if I was going to my physician and I'm saying I'm having these issues and it's out of their quote, like, to use your words, their toolbox.
Yes.
That they would say, okay, well, here, let's help you find a specialist.
The right person.
The right
to help.
person
Yeah.
to do that. I mean, that's just, and there's so many things to understand about women's health and women's hormones.
Can we go?
Yeah.
I want to keep going down this road, but we never really got to what is menopause and what is perimenopause. Just because I know what perimenopause is. I don't know what postmenopause and.
Oh, okay. I'm sorry, Steve.
well,
yes,
That's a great question.
Yeah.
yes, because there is going to be a
I'm
test.
the man in the
There's
room.
going to be a test
I gotta know
afterwards.
so menopause. What are the things that you look for, and then what happens in postmenopause?
Well, the funny thing is I've got papers with me, of course, today, and I laughingly with my son before I even got in here, he's like, "Mom, you've got so many papers." I said, "Jason, I feel like I'm studying for the boards again, I got to make sure I know my stuff, and but family behind me, supportive and wonderful.
Awesome.
But perimenopause, once again, it could be 4 to 10 years prior to menopause. Symptoms start happening. You start having some irregularity with cycles, that type of things happen.
Got it.
As we see eggs, the number of eggs we have starts to dwindle. The brain is starting to talk to the ovaries and try to tell it what to do, and it's just not listening anymore.
And that's when menopause starts?
So menopause is a point where you have not had a period
For 1 year.
For 1 year.
Okay.
Remember
Okay.
that. That's going to be on the test.
All right,
Yes.
Okay, so
all
we'll
right.
test.
I'm making my notes on my hand here. So.
So no period for a year. We consider you menopausal.
Okay.
Now I have heard many times lectures, continuing education, that once you hit menopause, basically you're postmenopausal. That you're there.
Okay.
You're there. I don't really distinguish between menopause and postmenopausal. You're just in menopause.
Okay.
That can last from 10 to 20 years, many times with patients having symptoms after you haven't had that period for a year.
Okay.
Menopause can last 20 years.
It can last, the symptoms that patients have, yes.
So what happens? Well, it's 20 years. Is there what happens after 20 years?
We stay on the medicine.
Okay.
If you're still doing well, there's no contraindications. There's many benefits for it.
Okay. Yeah.
And so the medicine that we were talking about, or we're talking about, is it's so confusing to the layperson. There's estrogen, there's progesterone, there's testosterone. There's people with a uterus, without a uterus, with ovaries, without ovaries, and then there's the gels, the shots, the creams, the pellets, the suppositories. Like, where do you start?
gosh.
Yeah.
Where do you start? You go to somebody that wants to listen, and then the treatments are always not going to be specific. You really have to look at the patient. What does it fit for that patient? Now, there's specific ones that I do in our practice. We do not do pellets. Not necessarily FDA approved, and also something that I find once a pellet gets into somebody, you can't take it out. And if you're having problems, I can't adjust it, I can't remove it.
Because it dissolves into the skin, starts to dissolve? Okay.
Correct. And
I likened it to filler in your face. It just moves somewhere else. It
gets absorbed, and you may have complications with it, but you can't take it out.
Okay.
So we in our practice do not do pellets. I actually don't use a lot of oral estrogen. The first pass, when you're using estrogen, it goes into your liver. And what happens with that, and that's one of the things that actually happened in that Women's Health Initiative that I was talking to you about. We use more bioidentical or plant-based medications now, estradiol. It's not synthetic, but when you're giving that orally, it actually increases the clotting risk.
Okay.
So we try not to use oral estrogen if we can. So if you're looking at estrogen, a couple of different ways that I do it in our practice, we use patches. Patches are good for a lot of people. They don't want to have to remember to take medication every day or do something, so they slap a patch on their lower abdominal area or the buttocks area, that type of thing. They change it out usually twice a week. and they're great. We can adjust those doses if needed. Gels are great.
Is that gel what you just spray it?
That's what
put
I
it on
do.
your arm?
I put it in the crook of
Yes.
my arm. This is what Gretchen said. She said, just put it right here, put it on the crook of your arm, and you rub it on there, and it dries real quick.
It
and then
does.
wash your hands. And I told her, I said, I'm not washing my hands. I take the leftover and I put it on my face, and then I mix it in with my skincare.
You're not the first person that said that. There you go.
Finish so we're telling the other types of
Yes.
treatments, and then I have a follow-up question.
Okay,
on that.
perfect. So we have oral estrogen, we have patches, there's the pellets, we don't do those. We have gels, which estrogel is actually my go-to on that. And that's, once again, those hormone replacement clubs. Those are the companies that can get you at a less price on those. There's a few there's compounding medications you can get through pharmacies. Those are typically not covered by insurance, but I typically don't start with those. I go more towards the FDA-approved ones that we can get. Now, you talked about uterus, progesterone, those type of things. If you, in fact, have a uterus, you haven't had a hysterectomy, we do require you to be on progesterone at the same time you're on estrogen, and there's a couple of different things for that. The number one reason of that is because the endometrial lining, which is the lining right inside the uterus that when you had a period, you sloughed off every month.
Yeah.
If I just gave the patient estrogen, that lining would grow and grow and grow and could lead to endometrial cancer.
Okay.
Oh, really?
Yes. So that's the whole main key about progesterone. We give you progesterone, and it helps to keep that lining thinner.
And that is someone with a uterus.
With a uterus.
Okay, so then with a uterus, with ovaries.
Yeah. Okay. What about without a uterus?
But without
So-
a uterus, with ovaries.
It's a good question. Just going back on the progesterone one more time. Helps with the endometrial lining, but also this is what a lot of women, and we can use it with or without a uterus for this. If they're having difficulty sleeping, you take progesterone right before you go to bed at night, and it kind of helps you to drift off a little bit easier.
Interesting.
So
Okay.
now, if you don't have a uterus, you don't have to have the progesterone. The ovaries, it doesn't matter. We can just do estrogen. And if you just have ovaries, no uterus, you can do estrogen or estrogen and progesterone. But it is required if you have a uterus that you do take
So
progesterone.
if somebody goes on estrogen, specifically the gels, what I'm asking about,
Okay.
what kind of side effects could they expect to have, and how long would those side effects last? They just started it from scratch.
Yeah, started it from scratch. Of course, there's always a risk of a cardiovascular, heart attack, stroke, a clot. We always give precautions for shortness of breath, chest pain, swelling in a leg, those type of things we want to look for. Sometimes women can have a little bit of breast tenderness because we're giving them the estrogen, of course. Sometimes we might see a little bit of mood swings, might make you feel a little bit of a flush every once in a while when you're starting the medication off. But most women, by the time they come back in their 1 month follow-up, I tell them if you have, 50% improvement with the symptoms that they've been having, we're doing well.
It's not a magic. It's not a magic thing, though.
Correct.
So, how long once someone starts taking estrogen for them to start seeing any kind of improvement, or when maybe I need to up the dosage a little bit?
Once again, we want to make sure we go by patient symptoms, not so much labs. But I usually bring a patient back right about a month after being on the medication. I make sure that we really document at that initial visit what the symptoms are that the patient is experiencing. When they come back in a month, I always tell my patients, it is not a magic potion. It is not a magic pill. If I can get 50% improvement at a month, then we're doing great.
Okay.
Oh, that's
We do it. We're hitting a home run here.
Yeah.
So this is not just you go to your doctor once and they give you the pill and off you go, and a year later you check in with them. This is like you got to have a relationship. You got to be talking to the patient. They've got to be talking to you, telling you what's going on till you get the dosage right and get everything figured out.
Yeah, dosage plus other things that we can add to the whole outlook here. And that's the thing. I try to start off slow. We add one piece at a time so that if the patient is actually having a complication or a side effect, I don't have to throw everything out at one time. I can piece by piece it together. And my patients know when they come in, we've got a plan, but we're going to step through it, very gradually and add stuff as we need to go, even down to, adding vaginal estrogen, even if we're taking estrogen topically or what have you.
Okay.
What do you feel, I know patient by patient, but what do you feel has a better absorption rate? I mean, as far as like the gel, I know that I can sit there and, I'm waiting for it to dry, or I do my little hair dryer to try to get it to dry fast. But then I've also heard, okay, so the transfer rate, if I'm picking up my granddaughter or it's on my clothes, I get dressed too early, or I pick up my animal. Is there some sort, if I'm hugging my husband,
Right.
is he now getting some of that rubbed off on him, or should I do it?
Really and truly, manufacturer, and don't quote me on this, but 20, 30 minutes, you should be fine.
Okay.
And putting on clothes, I just tell you to make sure it's dried before you put it on.
Okay.
Gretchen, how often do women come in with their partners when they see you?
Every once in a while.
Okay, so it's not very common.
But it's not as common that they come in, but when the woman comes back for the 1 month follow-up, I usually hear, "My husband loves you." Well, thank you so much.
Yeah.
I want to ask about one thing that we didn't talk about testosterone and the controversy kind of surrounding it, whether to take it, whether not to take it, and the side effects about it. And once you told me the side effects, I was like, oh, but there are sexual benefits to taking testosterone, but there's also some side effects with that. Be as candid as you want.
Okay,
yes.
We're going here. Testosterone is something that a lot of women do come in asking about. And if we're starting hormones, once again, I start off slow. We don't add that initially. Then we can add it if we need to. The FDA does approve testosterone for decreased libido. That is the single one reason. A lot of people think they're going to get it for muscle mass, for fatigue, potentially even weight. But it is FDA approved for decreased libido. So we have to look at it. There's a lot of factors that go into decreased libido. It could be self-care measures, you exercising, your health. What does the relationship actually look like? If we can cover all of that and we still need the testosterone, fine. Testosterone does have some risk. They can be from clitoral enlargement that actually may not go back down. You can get hair growth at the site that you're using it. You can also get a change in your voice. So there's a couple other things that can happen because it's a male hormone.
Oh.
There can also be some cardiovascular risk with it as well. And that's why we want to be very cautious in using it, but not opposed to using it. We also, that is one that we do have to watch with blood levels to make sure we don't have you outside of a safe zone.
And there's a new medication, right? Didn't you go to some conference and there was something that was being released?
Yeah, there's a Dare to Play, or I think that is what it's called. It's out of California. It's not in Texas yet, but it's actually going to be a cream that you can put externally on the vulvar area and clitoral area that actually helps with stimulation, also potentially orgasm. We don't have that here quite yet. I do know some pharmacies here in Austin that make, we call it Wow Cream. That can,
I've heard of it. Yep.
So a lot of women have, and we prescribe that. That's not a problem, but it just can help with stimulation as well. Because what you, once again, have to think about, there's estrogen receptors all over our body. And we have estrogen receptors in our vulvar area, in the vagina, in the urethra, and the bladder. And so when that blood supply is not getting to that area, we lose that sensation. The skin becomes more fragile, more painful intercourse. You don't have that stimulation potentially down there. So
UTIs in older women?
Very much so. That's a great point, because we know that, and that was one of the conferences I just got back from Las Vegas. It talked about how, so it talks about how vaginal estrogen, even if a patient is not taking topical or transdermal estrogen, that vaginal estrogen can be taken alone if the patient doesn't want to be on anything else. Not only does it feed that estrogen into that tissue, but for urinary tract infections, we look at the women that are actually our moms, our older population that are in nursing homes. And one of the things that these women die from is they have a urinary tract infection.
I've heard that.
And then it goes into sepsis, and then they die from it. So what happens is stenosis, or narrowing of the vaginal area, occurs. The urethra is actually pulled closer to the opening, and it increases the risk of urinary tract infections quite a bit. So being able to get that estrogen in that area is very, very important.
It also, a UTI in older women can kind of mimic dementia also, like some
Correct.
cognitive decline.
A friend of mine went back home because his mom was exhibiting dementia, and they checked her into a care facility and they tested her for UTI, and they treated her for that, and within a couple of days she was right back to her normal self.
She's back to normal.
Yeah, isn't that crazy?
It's really sad.
Yeah, it is. I was gonna go. You were mentioning a few minutes ago about how men's health seemed to be more focused on than women's health, and you're talking about like these treatments to help women with their sexual
Health.
Thank you. And Viagra's been around for 30 years, and that's just like a mainstream thing. And then all of a sudden, now 25 years later, okay, now we can talk about women's sexual
absolutely.
health?
And so we're going to just jump right into the sex question too. I mean, just even more so. But so many times I hear women say this term: why doesn't the women's sex drive work like a light switch? Why doesn't it just turn on like a man's?
It doesn't.
No, it doesn't. It doesn't.
I'm kidding. I just did that just for you.
Thank you.
Make you feel
well,
better.
I guess to follow up on that is what is happening hormonally when a woman says, "Look, I want sex, but my body just won't cooperate with me."
Right. And we do have to, once again, we have to look at the big picture. What all is going on? How's the relationship? Is she exhausted? Is she taking care of children at home? Is work really, hard, very stressed? Stress can put a lot on a patient. Family things that might be going on. Whenever we look at that, women need a little more foreplay. We need to be kind of stir the pot a little bit as we go through the day, and that helps with stimulation, that helps with lubrication, where I think sometimes men, it's a little bit quicker.
I think so.
Do you want to tell us about that?
No, I don't really want to talk about it, but it is a light switch in men, I can tell you that. And that light switch goes like poop, like that,
right?
Yeah.
We just need a little more TLC, I think, as we process through there. And then hormones can also play a role in that too. I always tell my patients when they walk into the room, there are 4 walls that are around us, and this is a safe area. And I talk about pretty much everything. So for people that might be listening right now with small kids, maybe not, might want to turn it down a little bit. But I mean, we can talk about what lubricants are great for you. Are you on vaginal estrogen? How do you incorporate devices into a relationship that, it really and truly, and this is one of those things that are out there, for women to actually have an orgasm with penetration, maybe 18 to 20%, maybe a little bit higher, actually can have it with penetration. Most times it takes a little bit more stimulation to be able to get that.
Like a new car.
Exactly.
Jeez, God.
Little jewelry,
Do the dishes.
You
put the laundry.
I'm probably going to get myself in trouble here. But
probably.
from a man's point of view.
Yes. Tell me.
I think women think sometimes all we're about is that act and that release, and we're moving on with our life. And it's actually, for most men, it's a way we check in with our partner.
Yes.
To make sure that everything's okay. You got this crazy life, there's kids, there's sports, there's dinner, there's blah, 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 PTA. And you go, okay, are we at a point now where we're going to let down our guard and come together and enjoy each other? And if that's okay, then we feel like, okay, we can keep on with this battle.
Exactly.
And I think sometimes women, sometimes they're like, hey, I need a spray bottle. And it's like, hey, maybe your husband just needs to make sure you guys are doing okay.
No, I totally agree.
Well, but we're also not a drive-through restaurant.
No, I'm not.
We're a several course meal.
I'll let y'all do this conversation.
And I get that. But I'm just saying that it's not always like when you're 20 years old. It's like, boom, out of here. I got it. I'm done. But when you're older and you're in a relationship, there is a component that the man needs to know. I'm out there doing my thing every day, and I hate this and I hate that, but I'm gonna do it because we're doing all right.
It's an emotional check-in,
yes,
right?
It is.
Yeah,
It is.
I agree.
There's a beauty. There's an intimacy that
There
comes
is.
with that. And just even when you think of the skin and the hormones that it releases with the touch,
Yep.
they say it brings down your blood pressure,
Yeah,
your
yeah.
anxiety level. You're there. You're in a comfortable zone. You're safe with consenting adults. And so, yes, there's a lot of things. And I do agree with you. I have a special one at home myself, so he's pretty amazing. When you talk about that, really leaning into that partner and being able to have a very open discussion. When there is a safety and a freedom to speak of what feels good. Let's be honest. What feels good? What makes you tick?
Yeah.
Because you may not know that, or if you're embarrassed, or you don't want to say anything about it, or you're just assuming. Assuming is not a great thing.
No, it's not.
Or you grew up in an ultra-conservative Baptist household where you never even talked about your.
But you also put your partner in a position where they're guessing. And if you have somebody that loves you, they want to make you feel good and they want to make you enjoy the experience. And if they're just guessing, they're probably not going to get it right.
And I think that there's lots of information out there. There's podcasts about this. There's a place in Austin, a boutique, ELLE. I think it's L or whatever.
Yeah.
I mean, they go through all of that stuff with you. They have devices there if you want to talk about that. They have lingerie. They have it, but it's very upscaled and it's very nice. And to be able to go in there and just kind of see what's available. But being able to talk to that partner, I think, really opens the doors to that intimacy and a check-in, like you said. Is everything okay? Are we comfortable here?
It's also, life gets so crazy. It's a time where you can kind of block that stuff out just for a few minutes. And
that's why it's nice, I feel, at times to get out of the house and vacation man is what I like to call it, right? Vacation man and wife. Because I'm not thinking about the dishwasher or the washing machine or the pool guy or the dogs are there, or one of our.
I think it's good for everybody.
Yeah, you just got to get away and you can just focus on your partner, whatever it is. Doesn't necessarily have to be about sex, but you're right. It's about that intimacy and being close.
Yeah,
It's a check-in. It really is.
Yeah, it's so important. I feel bad for people that go long periods of time without that. That's going to make a relationship suffer.
Yeah, it's my husband and I really take time in the evening just to look at each other, check in, see how we're doing, and then really and truly taking those opportunities to have date nights to really foster that relationship and that you connect. And where am I maybe missing it, or how can I, really listening to that person to see what they need.
Yeah,
you're truly about the mind, body, and spirit, though, too. That's what I loved about you. It wasn't just about pushing medications down my throat.
That's a great segue to my next question.
Right, it is.
So, Gretchen, what are the other things? Somebody's going through menopause. What are the other things they can do to help with that besides just the therapies? Like what else? What other things can a woman do?
You mean the medicinal therapies?
Yeah, besides the medicinal therapy. You mentioned exercise. What other things can they do?
Well, whenever you look, we want to have the healthiest body that we can, longevity-wise. We have the hormones. That's, estrogen receptors all over our body. So when we're feeding that back into those cells, they're absolutely able to function. I always talk about, if a patient's a diabetic, are you going to give them insulin? Of course. So when a woman, if you are a candidate for it, if your ovaries aren't working, let's give you hormones back.
Yeah.
But what else can we do on top of that? Exercise, number one. Keeping healthy. We want to have a healthy diet. Protein, more protein. I laugh with my patients all day long. I am terrible at it. I cannot get enough protein in, but I try really, really hard. Exercise, especially in perimenopause and menopause, you have to be doing weight-bearing exercises.
Oh, that's important.
Stop looking at me, Mallett.
Sorry.
Stop looking at me.
You have to be doing weight-bearing exercises, not only for muscle mass, but just bone health. We know that estrogen helps protect our bones, decreases the risk of osteoporosis. Those fracture risks do go down, but we want to continue to maintain that and help it any way we can. And so definitely exercise. So diet, exercise.
What about the introduction of all the semaglutides and trizepatides and stuff like that being introduced? It's not a quick fix for anybody, but also sometimes it can help turn off that food noise.
Absolutely.
And jumpstart where they felt hopeless. Are you recommending?
Do I recommend those? I think they fit with a lot of people, can be successful. Everybody, once again, is not a candidate. They do need a lot of primary cares will do that. We don't actually do those in our office, but I have a lot of patients that are recommended for. We find a lot of insulin resistance that occurs in perimenopause and postmenopausal women. And so having those GLPs, Zepbounds, weight loss, a lot of times women just need to get a little kickstart sometimes. And that helps with so many things in the body, from cardiovascular, they're finding
dementia, arthritis,
everything, their joint pain. And just bringing that weight down, it makes you feel good too.
Yeah.
Let's be honest.
I have a friend that I met her running marathons 10 years ago, and she gained a lot of weight, and she was not able to do all the things that she wanted to do, and you could just tell she wasn't happy, and she got on something and she lost a lot of weight, and we just saw her a couple weeks ago. And it's been amazing to me, the difference. She's got her confidence back. Her skin looks better. She's carrying herself differently. And I was like, okay, if there's ever a poster child for these injections, that she's it. And I was really glad to see her back to what I consider her normal self. Because when she was really heavy and she was carrying that burden, it wasn't her anymore. It was her, but you know what I mean? It was like you could just tell it was
heavy on her.
It was heavy on her, yeah. And
not only the weight, but just emotionally.
And so now I'm sure that her relationship with her husband is better and all those things. So that's been a wonder drug for her.
Gretchen, you go to a lot of these conferences and you specialize in women's health. And I know this isn't your specialty, but equally, this is an embarrassing conversation for a lot of people. And even myself, when I was in your office, I remember I was asking you a question and you looked at me and you said, "It's okay, Michelle, you can ask the question." And I said, well, I'm trying to say it like we're not making me embarrassed asking you the question, but we're talking a lot about women's health and how it changes over the years. And then we'll just take a little bit of shift. And then the same similar things happen to men's health as well. And as women, we need to realize that too, where I have a graphic pulled up with the testosterone. Did you just see how I said that? How did I say that?
Testosterone.
Testosterone.
Yeah.
Now I can't even
we
say
knew
it.
what you were talking about.
Testosterone production, they gradually decrease the sperm production, but it does not stop. And not all men experience low testosterone and sperm production. So there was menopause women, and what was the andropause? Is that what they called it for men?
So I'll be 63 in a couple days. And
Happy birthday.
Yeah,
That's
thank
right.
you.
On
Valentine's Day. Yeah. And my free testosterone is actually pretty high for my age, but I do triathlons and running and stuff, and I know guys that are on testosterone and they're kicking my ass and they look way better, and I can't get on testosterone. That frustrates me.
Does it?
Yeah, because I'm not eligible for it. So because my free testosterone is on the higher end.
I wonder if it's for men too. Like your baseline was
I
this,
think it
or every
is,
time.
yeah. And I work out like 12
Crazy.
hours a week. Yeah, I weight lift, swim, ride, run. And
I don't work out at all, Gretchen.
Yeah,
At all.
I know.
It's a problem.
She's blessed.
I won't document
She's
that,
got,
okay?
She's got good genes. Yeah. Anyway, I sidetracked that. I'm sorry.
No, but
in
how?
men's health,
Yeah, but when you're dissecting those paths, when those paths are crossing, the men and the women. So the women, now we have tools in our toolbox to be able to use. Where do men go?
Where do men go?
For the same similar
good question.
issues?
And I will tell you, this is not my expertise.
Yes. Sure.
However, urologists are a great place to go. And once again, you want to find a urologist that is actually willing to listen. Because blood work can tell us one thing, but it's not always the end-all, be-all. Okay. So in your situation, I don't know where your testosterone falls or, total and
Give it to me and I'll put it up on the screen.
No, we're not doing that.
We won't go there. But, I just say make sure you've got a urologist, one that actually is listening to what your symptoms are, making sure that you are really seeking out that person that can be there for you. But it is transition. As we know, everybody ages. It's inevitable. It is inevitable.
Yeah.
But as we age, we want to give us the best quality of life that we can.
You're doing everything right, Mallett.
Well,
except
the phrase that keeps popping into my head these days is nobody gets out alive.
No, we don't. We don't. That is inevitable. But yeah.
No, I actually feel pretty good for being almost 63. I'll take this. I was thinking about it this morning that I'll take this body and this health any day of the week at my age. Yeah, I know plenty of people that are younger than me that are, not doing well.
That struggle.
Struggle, yeah. So I feel blessed.
Is it ever too late to start, kind of back on that 10-year time, is it ever too late to start treating the symptoms?
Well, if you're 60 and you've never been on it, or you're postmenopausal 10 years or plus.
Okay.
Now, I do have other medications that we can help with symptoms. If it's hot flashes, night sweats, there are new medications on the market.
I saw that.
Yeah, Veoza is one of them. There's a new one that Bayer just came out with as well that can actually help with those vasomotor symptoms like the hot flashes, night sweats, but it's not necessarily going to be the estrogen feeding back to the cellular level.
Is gabapentin one of those things?
Yes.
Okay.
Yes, gabapentin can help with some of the symptoms as well. Sometimes we use SSRIs like Lexapro and medications like that can help with women with symptoms.
Okay.
It's just not the hormones that we're going to be doing.
I'm sorry, go ahead.
No, that's fine.
Are you seeing new patients?
Absolutely.
Okay. So
Absolutely.
how can somebody that wants to talk to you, how can they find out and make an appointment?
Yeah, so Ascension is currently where I'm at, and you can also give them a call, 512-324-3410.
Okay.
And we can set up an appointment. We'd be happy to do that, and just make sure you always tell them I'm coming in for an initial hormone consult, and that's a specific spot in my schedule because I definitely want to make sure that I can give every single patient that walks in that door that quality of care that I want for me, my sister, my mom, anybody else. So
I wish there was a urologist version of you that I could go make an appointment with, because I could just tell that you really care about the people that come in to see you.
Well, and
Absolutely.
I think women have suffered in silence for so long, and having this on the news cycle, it's not just it is not just a news cycle, right? This is our moms, our grandmothers, our sisters, our wives. This is us. What do you think is the biggest lie women have been told about menopause?
Ooh.
the biggest lie is that just deal with it.
Grin and bear it.
Grin and bear it. Just deal with it.
Yeah.
It's all in your head.
It's all in your head.
The funny thing is a lot of it is in our head, how our neurons work in our head, and even with the vasomotor symptoms and the chemicals that are produced in the pituitary gland and what have you. So yeah, if you want to make a joke out of it, a lot of it is in our head. But you do not have to suffer. You do not have to suffer. And if I could just get that information out to women, now, once again, not everybody's a great candidate, but there's so many things that we can do to help you. Mm-hmm. Don't sit at home and suffer.
That's the name of our podcast. You do not have to suffer. That's it right there. So
there you go.
Gretchen, I can just tell we've just scratched the surface on what you know about women's health, and it's been really eye-opening for me on a whole number of levels. And I know you had to drive a little ways to get out here. And
it's perfect.
I thank you for your time today.
And we apologize for the
the lawn guy.
The lawn blowing in the background.
I swear, I think he knew we were recording, and he did that on purpose.
He gave us a little challenge.
Gretchen, thank you so much. You have changed my life with you've actually changed Steve's life too. He doesn't even realize it.
It's true.
I call Mondays Murder Mondays. So I don't know if it's him or me, but
You know, you haven't done one of those ambushes on me lately, so maybe it's since you've been seeing
maybe
Gretchen.
that's it.
Yeah.
Maybe I
She used
should
to
say
come in my office
So
and
you're
shut the door.
supposed to thank me for
I'm
that.
thank you, Gretchen. She used to shut the door and come in my office and sit down. I'm like, oh crap, I'm in trouble. And then 3 hours later, I was like, oh damn, what did we just do there? But she doesn't do that anymore. So thank you, Gretchen.
You're so welcome.
I'm saving it up because we have a podcast now. I could be implicated
Yeah, that's
on a
right.
bunch of
That's
stuff. But
right.
no, thank you so much for coming. We appreciate it.
Love to come back anytime.
Thank you. All right, good job.